Yeah, so thanks so much, and very good to see all of you, not on one screen at a time, but thanks for joining us. So as Nicole said, we're going to try to keep this to an hour, so I'll try to keep my talking to about half of that, and then have time for questions. And of course, if we don't have time to get to everybody's questions, you know where to find us. So again, thanks for joining us. The slides visible?
Yes.
Everybody? Okay, good.
Yes.
So, oh, great, thanks. All right, so this is an update on the New Jersey Population Health Cohort Study. This is what I hope to cover today. The all-important acknowledgements, a little bit about our team and some changes we've made, and then walk through sort of a high-level description of what we are doing, how we're thinking about things, and what we are planning for the near future. So always start with the acknowledgements. The cohort is funded by the Robert Wood Johnson Foundation with an additional contribution from RBHS. The chancellor put up matching funds. We're very grateful for that. And I just want to note that this is a little bit of an unusual investment for RWJF. I was told this is presently their largest study that they're funding. I know they've funded larger ones in the past. And you know, they took interest in this because of their own internal priorities, and hope that this study can contribute to advancing their goals as well. And that's often the case with every funder. But as we negotiated the scope of this with them in the grant, it's very clear that their main interests are about health equity, and especially racial equity. They'd really like to see this study be useful for action-oriented work in New Jersey, meaning policy change or programmatic change, eventually evaluating changes and natural experiments that occur. So they have a really strong New Jersey interest here, a health equity interest here. It was really important to them that these studies be broadly representative of the diversity of New Jersey's population. The conversations about funding the study started years ago, really when Shin-Shi started as institute director and was making the rounds and sort of piqued their interest, sort of building on his work on the Pine study and other things. That led to a negotiation over the scope, and you'll see where we landed. As I'm sure almost everybody on the call is aware, he's no longer involved. He's no longer director of the institute. He's no longer involved in this study. And I mention that mainly to sort of explain that we made sort of a pivot in how we're implementing this. Earlier this year, when it was clear he wouldn't be coming back to the study, I brought in a team of experts who could complement my own expertise, and you'll see who they are in a second. And you know, we had to sort of make over the design to fit our interests and needs and make sure we could help this, you know, make the study succeed. So there's been a little bit of an element here of building the plane while we're flying the plane, which is not ideal. But I think we're succeeding in doing that, and so far haven't crashed. So also want to acknowledge and thank really a large group, too many to mention, Rutgers and other colleagues who sat in meetings with us early on to think through this design, and some of whom are involved sort of more intimately in specific pieces of this. And we will you know, have and will remain sort of instrumental to what we're doing here. And also, I'll talk about our colleagues from RTI, but a couple of them are listed here as well. We should thank them. And Katie Morton, I think, is on the call. So anyway, a little bit more in a minute. So this is the reconstituted leadership team as of the beginning of this calendar year. I think everybody on the picture here is also on the Zoom, and sort of across the top row are the sort of the senior team, design team, leadership team. And then Stephanie and Dan, really instrumental in study operations and all the million details that need to be taken care of here. Margaret, helping to steer this battleship through Rutgers, which those of you who've done large studies know what that's like. And also Steve Cohen, who is our statistical consultant on the sampling and one day weighting of our data. And he's also on the call, along with Katie from RTI. So also want to really acknowledge and thank the team, our field staff, coordinators, research assistants. Not quite everybody is listed here, but most are, and I think most are on the call. Not pictured here, although my oversight is I should have especially thanked Nicole, who introduced me, not because she introduced me, but because she's really been central to the sort of community facing and the public facing side of the study and remains integrally involved in our implementation. And a special shout out also to Dinesh, who is sort of keeping our infrastructure going, and that's been a huge amount of work, and he's been really instrumental. Everybody's been instrumental to this, and we're really proud of this multilingual, multicultural team that we have. So on to the study details. So our overall goal is to produce actionable, practical information for improving population health. Oops, sorry. Improving population health, back. Okay, population health in New Jersey, and to produce generalizable information on ways to improve health, well-being, and health equity. Specific aims are to discover ways that stressors that we face over the life course at the interpersonal, societal levels contribute to health and well-being outcomes, and then identify factors that buffer or amplify how those stressors influence our health and well-being. And we don't do this for our own health. We do this to produce information about health. So we really want to generate actionable information for populations that have special needs and the population at large, including with a special focus on intergenerational families, immigrant groups, people of color, and low-income families. So it's always good to start with a broad conceptual framework to help guide the design of a study. And this is where we have landed. This is, I think we've landed. We've been working on this really since the beginning of the year. Especially want to thank Paul, who has led our conversations about this. And you know, this feels pretty simple to me now. And when the model starts feeling simple, it starts feeling right to me. And so on the left-hand side, measuring the stressors at multiple levels, measuring the potential buffers and amplifiers, and then seeing how that translates over time. We hope we'll be able to continue this over time to look at impacts on the outcomes of interest. One starting point for this work is the really well-known publications by Case and Deaton from Princeton, documenting what they call deaths of despair. These are deaths from overdose and suicide and cirrhosis, and alcohol use, and so on. And that has created tremendous buzz in the public and in scholarly domains. And the sort of the despair part of this is stated, but not really measured. It's just assumed. And so that's sort of our starting point. And that's why back on this chart, you see, you know, the distress and despair along the pathway. Those aren't constructs we plan to measure to look at the causal chain there, but we think that's the pathway through which stressors, whether moderated or not, lead to worse outcomes.
Joel, can you say a little bit about why you think it's not, you don't want to actually try to measure it?
Can we hold that question? I think
Yeah.
it's a good one, and we've discussed
maybe,
it a lot.
Yeah, maybe
And
come back to that. Yeah.
We are measuring, and we'll go through the measures we have, and I think we are measuring things that are manifestations of that. But we're not going to do the psychometrics to come up with the despair scale. So I'm not saying we're leaving it unmeasured, but we're not making the measurement of it a focus of the work, and we can come back to
And would you say the same about sort of social constructs like distrust that have been associated with deaths of despair?
Well, those are constructs. I can't remember exactly what we have on distrust, but those we do want to measure the specific pathways and the mediators, the manifestations of stress, of how we respond to stress, and mistrust might be one of those things that can mitigate or enhance the distress we feel. So
right,
we do want to measure things along the pathway. And finally, just referring to in thinking about putting this together, we found the work by Nancy Krieger and colleagues, the Ecosocial model, to really be a useful guide to thinking about this. And I think it's also really consistent with RWJF's interest in sort of looking at the structural determinants of health and inequality. So that's sort of our leaping off point. So I'm going to sort of go through the components of the study at the 30,000 foot level, and then at the end, let's take any questions you might have about the details. So we ultimately hope to collect data from about 10,000 individuals, ages 14 and older in New Jersey, and it's split 60-40 between a probability sample, and I'll explain how we're doing that in a moment, and a series of immigrant samples selected non-probabilistically using respondent-driven sampling techniques. And you can see the list of the groups there. Those groups are selected because they are the largest recent last decade or so group of immigrants, with the exception of the asylee refugees, which are included because we think that they're very likely subject to a lot of stressors in their environment, and therefore are important to include. So specifically about the prob sample, the probability sample, it's designed to represent New Jersey overall and large regions of the state. It oversamples immigrants and multi-generational households. And it's designed to ensure adequacy of samples of racial, ethnic, minority, and low-income groups. And once we run the numbers, it looks like we have a tiny oversample of those groups. But really the goal there was not to underrepresent them. And it's a clustered sample to enable efficient in-person data collection. Could folks mute? We're getting a little feedback. Thanks. So as I mentioned in the intro, the sample design was really developed in collaboration and with the help of Steve and colleagues from RTI, and we're using the RTI sampling frame that they have to do the work, and they will ultimately create sample weights. So if we want to generate state estimates and regional estimates of things, we can. The probability sample uses 4 stages. First, we select primary sampling units, and these are PUMAs, for those who are into those levels of details. Those are nice, roughly equal-sized divisions of the state created by the Census Bureau. We are over sampling high immigrant areas. We will be fielding the data collection in 3 replicates with 8, 10, and 12 PSUs per replicate. And it's probably a stretch to say that each replicate will separately be representative of the whole state because it's so highly clustered. but they're designed to be broadly representative of the state. They can be put together at the end of the day, but it means that we'll have a round of data collection that has some generalizability early on that can then be used for preliminary studies. And you'll see why that's important. The second stage within the PSUs, we select secondary sampling units. These are built out of census block groups. Some of them are put together because to get the number of households per block group roughly equal. And we're selecting 23 SSUs per PSU. And again, at this stage, we oversample high immigrant areas. Stage 3 is within those selected areas. We'll, using the RTI sampling frame, address-based sampling frame, we are selecting 138,000 household units, about 200 per SSU. And I think RTI applied some innovative strategies here to use models to try to select households that are more likely to be multi-generational. And they train their model on some existing data they have and are able to sort of correctly predict a multi-generational household pretty well. So we think we have an oversample of multi-generational households as well. And then finally in stage 4, once we contact those households, we'll enumerate the families and the family members within each. If there's more than one family in the household, we'll select one probabilistically. And then within families, select one person per generation. And it's worth mentioning that we are not doing a detailed collection of how people within the household are related to each other. We're using a proxy for multi-generational. They're all related in some marriage or adoption, blood, and so forth. But we define each of the age bands here as a different generation. So up to 4 people per household, fewer in most. And then within the probability sample, there will be households that are eligible for the immigrant, that are part of the immigrant groups that we're interested in. And we'll use those as seeds, if you will, for the respondent-driven sampling. I'm not planning on spending time today on the RDS, but essentially it's a snowball style of sample. And when we do find a group, when we select probabilistically a family that is eligible for the one of our immigrant samples, we'll try to capture interviews with all family members. Okay, let me turn to data sources. And I think this is one of the, I won't say unique, but novel features of the study. And as we were sort of socializing our broad design with NIH officials, they, different NIH folks were sort of resonating with different parts of this. But there was a fair amount of excitement about the sort of breadth of sources of data here. So first, of course, we'll be interviewing folks using, to the extent we can, the available validated, psychometrically validated scales that are commonly used or approved for NIH studies. We'll be doing some measurement in person, height, weight, waist, hip, and so on. And for participants age 50 plus, we plan a battery of cognitive tests, and William, who is on the call, has been really helping us with that. Also, we are measuring activity and movement. I'll tell you a little bit more about that in a second. Measuring biomarkers, again, with William's help. And also planning and have already implementing extensive secondary data linkages. So I'll go through each of these buckets of data sources in just a little bit more detail. So activity measurement, movement measurement, for consenting participants, we give them some equipment for a two-year, in my dreams, a 2-week data collection period. We're using Actigraph Centerpoint Actigraphy watches, pictured here, and with a list of the measures sort of on the slide. I won't read it to you. We're also giving them a study cell phone, which uses GPS to measure their movements, latitude, longitude, altitude. New Jersey's pretty flat, but you know, this can change, and so on. Then finally, we also are using an app-based, cell phone-based brief questionnaire every day about sleep and movement during the 2-week period. The biomarker study, and I'm happy that my colleagues are here, because when you ask me hard questions, I'm going to call on them. So 2 sources of biomarkers: salivary DNA collected from all consenting participants, and we will be banking the DNA. We're not going to be able, people have asked me, are you going to run this, look for this gene or that gene? And the answer is, get a grant and pay for it. But William can talk more about this if you have questions. And then for a subgroup, I'll show you the sort of are thinking about this in a second, we'll be drawing blood to look for inflammatory markers, Alzheimer's related blood markers. So we start with all consenting participants, limit the biomarker data collection to those who consent for DNA, impose some inclusion and exclusion criteria, and on down to the bottom of the chart, we estimate that roughly 20% of the sample we'll collect blood from. And again, if you have questions, we can come back to this at the end. Let me turn now to the data linkages. We plan data linkages both at the individual respondent level and at the geographic level. We've done a fair amount of work already to identify the respondent level linkages of interest, and actually have started the process of collecting the consents, and have negotiated deals the wrong word, negotiated data access with Horizon Blue Cross for their commercial markets. We're in the process of writing applications to ResDac for Medicare and Medicaid. Some of the data are available through the IPHD program, which we also administer. And you can see the list of things that we're planning to collect. We've had conversations with all of the data holders, or most of them at this point. Some conversations are farther along than others. This, I think, would be one of the most comprehensive sets of linked data of any study of this kind. As I mentioned, we'll also be linking at the area level. We've kind of backburnered the decisions about what to measure there, because we don't need consent other than consent to participate in the study. And the data sources already exist. So, and we don't have to negotiate DUAs. So that'll come next. So last, let me turn to the interview measurement domains. And here I'm including not just immigrants, not just the interview instruments, but also sort of illustrating where these other data sources fit in. And they are color-coded, as you can see, for those non-colorblind people on the phone. So remember at the beginning, I said we're going to collect the interview data in replicates. So what I'm about to show you is the data that we're presently in the field in replicate 1, and these are the domains that we are collecting. And it's I got another piece there. It's a little bit of a work in progress in the sense that we've sort of settled on the replicate 1 instrument. The slides are limited in that if we're collecting data from 2 different sort of sources, we only highlight 1 here, but also classifying these measures and according to sort of which part of the conceptual framework they fit in is, that's a little fluid, and really ultimately will depend on the individual analysis that's being done. So we do think there's an opportunity to slightly modify the questionnaire for replicate 2 and replicate 3. And we are sort of carefully reviewing what we have, what we might be missing. We'll be seeking input on that. Of course, we ultimately want to pool these replicates. And so if the questionnaires are too different, then that becomes difficult to do. So we're going to try to maintain consistency, but have some wiggle room at the margins to update the questionnaire for the future replicates. So health and well-being outcomes, I'm not listing specific instruments here, but just the domains broadly in measures of general well-being, mental health, physical health, cognition, physical disability, morbidity and mortality, mainly measured. We do have some questions on chronic conditions, but it's mainly measured through secondary data linkages. And you can sort of read through the fine print here to see the more specific domains. Moving on to stressors, we at the personal and interpersonal level, we're measuring, it's in quotes, objective measures, because it's all self-reported, so there's an element of subjectivity there as well. But adverse childhood events, criminal justice history, so forth, I won't read it to you. You can see the list. Through secondary data linkages, we can get some additional rich data that really is objectively measured. And then at the, well, I should say the sort of second sub-bullet under personal and interpersonal stressors, one that we're emphasizing a lot because we think it's important, our funder thinks it's important, is the effects of perceived discrimination. And with help from our collaborator, Don Luzon, we've sort of updated made some modifications to sort of what we think are the best available perceived discrimination measures. At the sort of higher levels or broader levels, social, political, and societal levels, we're really interested in the kinds of things that we think are stressing people these days, but haven't traditionally been measured in instruments like this exactly the way I think they need to be. So we developed some new measures of the effects or exposure to stress from social media, climate, the climate situation, if you will, economic inequality, political turmoil, race relations, immigration, and gun violence. So this is feelings about these societal trends and how they may be manifesting in a person's own feelings of stress. We're capturing social determinants of health with some existing measures. And then particularly at the geographic level, we'll be attempting to measure environmental or neighborhood stress through some of the geographic data linkages. Buffers, amplifiers, and other variables. Always cover myself with other. So we don't have to debate whether something's a buffer or an amplifier. But clearly some of the biomarker work, genetic predisposition, for example, to certain outcomes is very important to measure. Psychological traits, relationships and networks. The multi-generational family aspect of this makes this very rich, we think. Health and health-related behaviors listed here. Healthcare access and utilization listed here, with some from external data, some from the interview data, some from both. A couple more, of course, sociodemographics and immigration status, detailed questions, socioeconomic status. And we're hoping to be able to link to about 10 years of historical wage and unemployment benefits data through a database that's available in New Jersey. Still have to work out all the legal details and get permissions. some of the secondary data linkage limitations, a major one would be is that a lot of these data sets are New Jersey only, not all of them, but a lot of them. Okay, so that's what I have for data collection and the different modalities of data collection. Just a couple of other things to sort of wrap up. As I said at the outset, the foundation and we as well are really interested in a strong community engaged approach. The strategy early on, before last, through say 2021, was a broad sort of institute-wide engagement strategy with health fairs and other things that we thought would reflect well on the institute, engage people. We could recruit for multiple studies. So we've pivoted away from that a bit and have created or are in the process of creating a study-specific community advisory board, where we will seek a sort of a strong, equitable, bidirectional engagement with them. It's too late to sort of influence the overall design. We'll be clear about that. But gathering from them information about what analyses are most interesting. How do we get the data out to community-based organizations to be useful? How can we be most culturally appropriate, culturally sensitive? And we'll need some help also with recruitment, particularly for the immigrant samples. We also have, from the beginning, had scientific advisory groups, an internal one and an external one, and we're presently reconstituting those. We had a state level policy advisory group. We'll continue that. And we will also continue our outreach and discussions with NIH officials and other possible funders, honestly. Which leads me to our sustainability plan. So it's very important that to note that the Robert Wood Johnson Foundation has made infinitely clear that they are funding this first phase of data collection, the design and the data collection phase. They do not want us to come back and ask them to fund follow-ups. Now we can apply to their competitive RFPs and so on, and we likely will, but there's no promise. In fact, there's a promise not to just sort of give us renewal continuation funding. Our sustainability strategy is really to early on engage our colleagues who are successful NIH-funded faculty to help develop and lead and collaborate on R01s and bigger grants. We're working on identifying funding opportunity announcements through the relevant institutes, and we will be working to put together teams for a first round of applications that we would like to be submitting next calendar year, the coming calendar year. We'll have good preliminary data from Replicate 1. We, as I said, will be able to tweak the instrument a bit if it means that it's on the critical path to getting a large NIH grant. We're being very practical here. Over time, we hope to then expand the range of colleagues who can develop proposals. Resources permitting, we'll be doing a competitive call for pilots in, say, 2 years hence, which can bring in some additional folks to generate preliminary studies for their proposals. Also, part of the sustainability strategy is we will continue our outreach to New Jersey stakeholders. We've been meeting with interested legislators. We'll be getting the word out broadly in New Jersey. There's always a possibility, and we at the Center for State Health Policy have succeeded over the years in working with, say, the State Department of Health, which has suddenly gets an RFP for a large tranche of money from CDC or HRSA or SAMHSA to do X. And it's like, well, what can we do? And we want to be ready there and say, well, we have this study, we can do an add-on, and we think there's some opportunity there. So we're working to keep those doors open as well. So just wrapping up with just sort of where we stand on the timeline. Our design phase started in 2021. We did a lot of engagement with advisors. We did some preliminary studies, kind of enumerated here. We worked on establishing the design overall, testing our data building and testing our data collection platform, recruiting, training, and engaging our staff. The all-important IRB application. And then starting this year, as I mentioned, we had a change in leadership. We really reviewed and revised our conceptual model and the research design, continued community outreach, finalized our Replicate 1 survey instrument, and got into the field. Actually, that's on the next slide. Got into the field in August, beginning the respondent-driven sampling, recruitment, conducting a pilot study for the biomarker work, and we'll do the full biomarker data collection in future replicates, restructuring our advisory structures, engaging a CAB, and so on. And then next year, we'll just continue study rollout, prepare that initial submissions of highly competitive, we hope, NIH proposals to continue the work on the study, and continue data collection. 2024, which is the last year we think we'll have funding from the current sources, sort of continue engagement, complete data collection, possibly conduct a competitive solicitation for pilot awards, and then continue developing new funding sources. And as I always say, it's not a cohort if you only have one round of data collection. So it's in this year that it has to be turned into a cohort. So I think that's it. So thanks very much.